Hi everyone. Thank you so much for joining us this evening. My name's Jyoti Nanda. I work with Zio Plus, and you may be familiar with our brands Utiva or Ferrosum. So yeah, we're really happy to have you join us tonight. Just some quick housekeeping before I introduce our speaker tonight. So the webinar is set to run for 1 hour, or will end at 8:30. So I'll do the introductions, we'll move into the presentation, and then leave about 10 minutes, hopefully, for Q&A. Any questions that you have, please feel free to drop them in either the chat or the Q&A box, whichever one you want. You can add them in. Throughout the presentation, we'll be making a note of them, and we will do our best to get through as many as possible at the end. The presentation is going to be recorded, so we'll send the replay out sometime next week, by mid next week. And I think that's about it. Oh, right. So after the presentation, we are going to be doing a raffle for the 2 Amazon gift cards. So please, if you're interested in that, stay on. It's a quick raffle, but you'll need to be present in order to put your hand up if we call your name. And then after that, for anyone who is interested, the Zio Plus team will hang on and we'll do a quick product presentation on some of the products within our portfolio. So feel free to join for that as well, if you'd like. Okay, and then with that being said, I will introduce our speaker tonight, Manjit Hansra, who's a pharmacist based out of Toronto, Ontario. So Manjit graduated from the Leslie Dan Faculty of Pharmacy in 2003 and has served as a clinical instructor at U of T since 2006. He is passionate about supporting patients living with diabetes and has obtained his CDE certification in 2011. Manjit was an associate with Shoppers Drug Mart for 19 years in Toronto before shifting toward his current roles as a consultant, a speaker, clinical pharmacist, and founder of RX for Renewal, where he builds and facilitates programs to support healthcare leaders and pharmacists to prevent and help manage burnout. So thank you so much, Manjit, for joining us this evening.
Great. Thank you for the introduction, Jyoti. Really appreciate it. It's really a pleasure to be here with all of you. I get chances to speak, but not a lot of chances to speak to a national audience. So I really am looking forward to today. When I was asked by Zio Plus to think of a title for today's presentation, I came up with Stop the Burn. And there's two reasons for this. Number one is because, as many of you know, dysuria is a primary symptom of uncomplicated urinary tract infections. But the second kind of double meaning here is the stop the burnout, which is happening in our profession with 8 out of 10 pharmacists suffering from burnout. So one thing that I would like to do, I know when I was in the audience to different types of CE events, I would work a day in the dispensary and then I would come to a CE. But a lot of the times I wasn't present because I would be thinking about all the stuff, the patient interactions, the issues with the physicians, even double thinking about a prescription that I checked, and I wouldn't be fully present. So what I would love to do before we actually get started into the nuts and bolts of the presentation today is actually do a breathing exercise. So with this, okay, I'll just do it manually. So I will invite you to close your eyes if you want to, but put your feet shoulder width apart, chest slightly out, shoulders slightly back. And what we're going to do is we're just going to take a few breaths here, and we're going to predominantly breathe through our nose on the inhale and really inflate our belly and then move it up to our chest. And the key with breathing is to slow down your breath. We always talk about a deep breath, but the focus is really to slow your breath and just follow my prompts. So like I said, I invite you to close your eyes if you'd like. The point of this is just to bring us all into the present moment. So in 3, 2, 1, we're going to inhale in through our nose for 1, 2, 3, 4, 5, and exhale out. 5, 4, 3, 2, 1, and inhale in through our nose, expanding our belly, moving all the way up to the top. Now at the top, I want you to take a triple breath in through your mouth. So, and hold. Relax your shoulders. Keep your focus in the middle of your forehead, holding your breath here. And then in 3, 2, 1, a slow, elongated sigh. Okay, inhale in, triple breath in through the mouth, expanding the alveoli to increase gas exchange. Now slowly exhaling out. 5, 4, 3, 2, 1. And last inhale in. Triple breath in and hold. And 3, 2, 1. Exhale it out, relaxing your shoulders, having your shoulders come down, and for you to sink back into your chair. So now that we're in the present moment, let's begin. Here are some of my presenter disclosures and some of my partnerships with other pharma companies that I have in my work. Talking about learning objectives. So the first of which, we're going to review the signs and symptoms of uncomplicated urinary tract infections. We're also going to discuss the management of recurrent urinary tract infections and also discuss strategies for prevention. So those are my learning objectives. This is what I want to share with you over the next 45 minutes. Now, I also want to take a moment for you to reflect and think about what your objectives are. Why are you attending this talk? You know, time is one of the most finite resources we have. We know this in pharmacy practice because anytime something else is added to our plate, we kind of fight back with, well, I don't have the time to do it. So you took time away from your family, time away from other activities that you could have been doing to spend the next 45 minutes with me and with the rest of your colleagues. So I want you to ask yourself, why are you attending this talk? You can feel free to add some stuff into the chat group, the chat box, and also perhaps, do you have a specific question that you'd like answered? And this would be a great time for you to actually think about that, because if you're listening to a presentation and you have a focus of what you want to get out of it, you're probably going to listen more intently and get more out of it yourself. So a little bit of background information. I mean, the stats speak for themselves. Some of these were very interesting to me, particularly the fact that UTIs are the 5th most common cause of emergency department visits, that 50% of females will experience their first UTI at the age of 33. And as pharmacists, we're accessible, we're knowledgeable, and we really have this opportunity to ease the strain on the healthcare system. I don't know how it is where you are, but where I am in Ontario, if I have to go to the emergency room, God forbid, I mean, I'm 6 to 8 hours, I'm waiting in line. So if there's anything that we can do to triage some of these patients and provide better care, not only on the treatment side, but also on the prevention side, I think we're doing a really big service to our communities and to our patients. There's different impacts that urinary tract infections have. I want to focus a little bit on the human impact. So 20 to 40% of women who experience one episode of cystitis are likely to experience an additional episode. And a quarter to half of those women are likely to experience multiple recurrent episodes. And there actually has been some data to look at the mental health component to women who have recurrent UTIs. And this was a study that looked at about 112 female patients, 8 of which had moderate depression, none of which had severe depression. And it looked at the rates of anxiety in this patient population. And what it found was that women with recurrent UTIs live in constant anxiety about sudden acute episodes and symptoms. It's almost akin to like migraines, right? We don't know what the pressure is going to be in the morning. And if we have a presentation or, important day that we need to be focused on, we could actually have a migraine come up that totally destroys that day. And UTIs, I would say, are similar in that way in terms of the mental burden that it carries and the level of impact that it has on the lives of everyone. Studies also show that anxiety levels positively correlate with the frequency of UTI reoccurrences. So the more frequent UTI occurrences, the more anxiety patients will feel. That's the human impact. There also is an economic impact. And the economic impact in Canada is about $350 million to the healthcare system a year. And treating a resistant case in the hospital can be in upwards of $20,000 per stay. So when we look at the opportunity, if pharmacists were able to manage 25% of all uncomplicated urinary tract infections, over 5 years, we would save the system $51 million. And the main reason for this was a study done from New Brunswick. and it looked at the cost of providing that care. And what factored into this cost was the cost of the care, the cost of the follow-ups, so the consultations, the cost of the medication, and also cost of any testing. So a pharmacist visit is roughly about half the cost of a physician visit. And that actually skyrockets to $368 for an ER visit by a physician, to a physician. The other thing is the fact that UTIs are associated with roughly 3,000 years of lost employment in Canada per year. And I mean, UTIs, we don't even typically consider them to be a serious disease, which is exactly what makes this number so surprising. And it shows that even common, seemingly minor infections can quietly drain the economy and people's lives in a massive and invisible way. So looking at the national landscape, we know that 10 provinces and 1 out of 3 territories have the ability for pharmacists to prescribe for uncomplicated urinary tract infections. And in a study done looking at just specifically Ontario between 2023 and 2024, out of the 13 minor ailments we have, UTI claims accounted for 34% of them. So I made a post on LinkedIn as well talking about the Pareto principle. And going back to the fact that time is our most finite resources, we as pharmacists, it's important that we spend time on those types of issues that we're going to be seeing over and over again. So I'm really glad that we have so many people attending today, because we're spending time on something that you're going to be touching each and every day. There's not a day that goes by where you're not filling a prescription for a UTI-related antibiotic, or counseling someone on prevention, or handling any sort of questions from our patients. So it's important that we spend time on those things that we're going to see regularly. A few definitions, won't spend too much time here. Urinary tract infection is an infection in any part of the urinary system. So that includes the kidneys, ureters, bladder, and the urethra. One thing I want to make note of is just the difference in anatomy between males and females. So on the left, you have a male. The average urethra length in a male is anywhere from 17 to 22 centimeters, which is roughly about 7 to 8 inches long, whereas the average female urethra is about 3 to 6 centimeters, which is just about 1.5 inches long. And also from the anatomical structure perspective, the male urethra is more complex because it travels through the prostate and the pelvic floor and the penis, whereas the female urethra is more of a simple straight tube. So that's why you see many more women having bladder cystitis types of infections, because the bacteria is just so much more easily able to get into that area of the body. And furthermore, just the nature of the closeness between the anus and the urethra. So getting into our first learning objective, talking about signs and symptoms. We have this differentiation between uncomplicated cystitis and complicated cystitis, where we see in uncomplicated cystitis the primary symptoms of dysuria and an increase in frequency and increase in urgency. On the complicated side, we see more systemic symptoms, fever, nausea, vomiting. We also see flank pain, so pain that's occurring in the low back, closer to where the kidneys would be located, whereas on the uncomplicated side, we see more localized suprapubic pain. We also see less blood on the uncomplicated side, and we see an absence of vaginal discharge, and sometimes we see some foul-smelling urine, whereas we don't see that on the complicated side. Excuse me. Just wanted to make a reference to a really good CPHA tool. This was back in 2021, but it really goes through in a step-by-step way how we can assess our patients, how we can consider goals of therapy and prescribe antibiotics, how we can counsel them, and also key aspects of follow-up. So I'll leave that there. It's just a 2-page document, but really useful when you're just going over things, or a really useful guide to share with the students that you might be precepting. So Scholar Hams, I never had the opportunity to learn this framework when I was in pharmacy school, but as I've been the attendance at many CEs, I found it to be a very useful tool to look at from a risk assessment and assessment framework, how we can use this. And I know we're all using algorithms and different programs like MedSask or MapFlow or something coming from the corporate side. But you always have those power outages where you don't have the ability to go ahead and ask those specific questions. So when we're looking at the symptom side, we use the acronym SCHOLAR, which looks at the symptoms, the characteristics, the history, the onset location, and what factors are aggravating things from an activities perspective or a food perspective, and also what things are remitting factors, which are helping to relieve the symptoms that patients are experiencing. So it's a really good framework for you to remember to go through the gathering of information aspect. Then we have the HAMS part, which is more on the risk assessment side. So what is the patient's health status? Do they have any allergies or intolerances? Are they on any immunocompromising medications? Are they using spermicides to disrupt the gut microbiome? Or are they using any other antibiotics that are leading to dysbiosis or an overgrowth of other pathogens or even yeast? So these are, like I said, a good framework that we can incorporate into our practice. Really important that we go through the red flags. All of our software will help do this for us. I just want to make a note of a few things. First of which is anytime someone presents as a male for this minor ailment, that's an automatic referral. Children under 16, very elderly, over 75. I would also perhaps put postmenopausal or perimenopausal women potentially in this group because they might benefit from other hormonal options in addition to an antibiotic at the time, which we obviously cannot prescribe. They must have a previous diagnosis by a physician, and if they have a previous episode within the last 4 weeks, then we also would refer them. On the recurrent side, the way that we define recurrent infections is 2 or more uncomplicated UTIs in the last 6 months, or 3 or more in the past 12 months. We also want to pay attention to the fact that are the symptoms presenting as systemic factors, or are they just more localized? And also renal impairment, because that can lead to antibiotic toxicity and also potentially have a lack of efficacy because the antibiotic isn't able to concentrate in the urine sufficiently. A reminder to when we're consulting patients. I mean, you guys all know this, prioritizing open-ended questions. I just very quickly want to go through an example of why this is so important. So I was doing a clinical shift, and a pharmacist who did a double the day before, and she was sharing this experience. So she worked at one store from 8 to 2, and then she left and then worked at a neighboring store from 3 to 10. And when she was in the morning shift, her last consult of the day was a minor ailment for urinary tract infection. And when she was asking the questions, the patient confirmed that she had a mild fever and she had some lower back pain. So what the pharmacist did was they referred the patient. Patient wasn't very happy about it, but they left. Her shift was over. She goes to the other store. And as she's walking in the store, she sees that same patient leave. So being curious, she goes and she asks the pharmacist, did you have a consultation with that patient? The pharmacist said yes. And, she said, what was it about? She said, well, it was a UTI. And I'm like, that's so interesting because I just counseled her about an hour ago. And when I asked her questions, I had to refer her, what happened with your interaction? And she said, no, I went through all the questions and, I prescribed an antibiotic for her. So this is an example where when we ask closed-ended questions, or if we're sitting in front of a monitor and we're asking, yes, no questions, patients are smart. Patients are going to know what the questions are, and if they're really adamant about getting an antibiotic, they're going to be able to circumvent the system to get that antibiotic. So it's just important for us to understand. That's where the scholar HAMS kind of comes in, where if you can have a conversation with the patient and gather the information, it makes the interaction that much more effective. And also maintaining professional integrity by recognizing the pressure to prescribe. I remember the first time I did my minor ailment on conjunctivitis, I felt this pressure to give the person an antibiotic. And I'd be interested to hear if you've experienced that same type of pressure, but it's really important that we maintain our professional integrity and we prescribe when it's meant and it's right for the patient. And we're very firm and confident when we need to refer. Looking at from an etiology perspective, in the community settings, we see E. coli accounting for 75 to 95% of uncomplicated infections. We also see some Klebsiella and Proteus mirabilis. On the gram-positive side, we see some Staphylococcus saprophyticus making about 5 to 10%. On the institutional side, we see E. coli making up about 50% of infections and enterobacteria making up about 40%. Antibiotic options. So you guys are well aware of all of these options, I'm sure. A couple of things to point out. We're looking at the resistance piece. So anytime you see more than 20% resistance, you want to try to stay away from that particular antibiotic. This is a recommendation made from the AUA and the CUA, which is the Canadian and US. They've come together to jointly provide guidelines on managing recurrent urinary tract infections. And this is a strong recommendation to provide antibiotics when necessary. So we see the first, second, and third line antibiotics. What are reasons for treatment failure? So obviously non-adherence is one. We are telling people how to take antibiotics, especially because there's multiple daily dosing typically involved. And we forget that when we're patients, how easy it is for us to forget to take antibiotics as prescribed. So this is still an issue, the non-adherence issue. The other thing is the resistance piece, where 25% of antibiotics prescribed in Canada are impacted by resistant rates. And if we go back to this recommendation from the guidelines, we see this thing called a local antibiogram. And what that is this is one that's provided by Life Labs. Life Labs gives you access to this type of information, like antibiotic susceptibility in Ontario, Saskatchewan, and BC. And in Ontario, it's great because it's actually sorted by LINS. So it's very specific information. And this is telling us, like I'm in Oakville here, so it's telling me what the susceptibility is to different types of antibiotics for E. coli, Enterococcus, Klebsiella, and some other types of bacteria. So we should log into this, we should find this and use it as a tool to help us guide how we're choosing which antibiotics to prescribe. So let's get into the management of recurrent urinary tract infections. I just want to lay the seed here to introduce you to Janine. She's going to be the case that we'll look forward to connecting with her later on. She comes to you on a Friday afternoon. I think I have another UTI. You find out that it's her third in the last 11 months, and she's looking for immediate relief, and she's really frustrated with these reoccurring episodes. So let's park this, and let's come back to Janine after we've gone through a little bit more information. So just a moment here to talk about this pivot from reaction to prevention, where our healthcare system is really built on focusing on immediate symptoms and spending less time on focusing on long-term health. And it's this whole idea of medicine 2.0 versus medicine 3.0, where medicine 2.0 is this reactive model that is really focused on treating disease once it's already occurred. Whereas medicine 3.0 is this more proactive model, right? Where pharmacists lead through proactive education to decrease the impact of disease before it actually starts. And as pharmacists, I mean, we're accessible, we're approachable, and we're knowledgeable. And I think that we have a great opportunity to lead this shift in community practice. So with that, let's start with our first poll question of the day. I am going to launch this bad boy and hope it works. Okay, so which non-pharmacological strategy has the strongest evidence for preventing sex-related UTIs? So drinking cranberry juice immediate after sex, using abdominal hot packs and warm sitz baths, emptying the bladder 15 to 30 minutes after intercourse, or taking a high-dose oral probiotic supplement daily. So we'll just give this a little bit of time. We have about 40%. I'll wait for like maybe 55, 60, and good. So we have, I don't think you guys can see the results, but I'll just share them with you. So I have 6% for A, 85% for C, and 9% for D. So yeah, the correct answer is emptying the bladder 15 to 30 minutes after intercourse. I think I can share these. Okay, good. Awesome, thank you. Poll number one works. So what are some non-pharmacological strategies that we have? Well, hydration, really telling patients to increase fluid retention. It prevents the bacteria from getting higher and higher, leading to pyelonephritis, and it encourages it flushing out the system so we're not getting more serious resistant types of infections. Wiping front to back, we know that, and avoiding immediately after intercourse, very effective. From a non-pharmacological perspective, and also avoiding spermicides. If your patients are using spermicide, it's going to disrupt the microbiome, and that can lead to more infections down the road. So now let's shift and focus on strategies for prevention. And When we're talking about prevention, we're really going to be focusing on a couple of different buckets. First, I want to talk about the pharmacological, both the continuous antibiotic regimen and also one that's focusing on post-coital use of an antibiotic. We'll look at non-pharmacological options, and then we'll also very briefly talk about the role of hormones. So from a pharmacological option, we have two options. Obviously, we're not going to be prescribing this, but this is something that once we know this information, it is a recommendation that we can make to our patients at a later state, where we can make the recommendation to the physician, because the physician might be missing it because the patient might be going to different pharmacies. And you obviously have more touch points with patients than a lot of GPs or family doctors would have. So daily dosing or intermittent dosing with sexual intercourse. Duration typically lasts from 6 to 12 months, and the effectiveness of the antibiotic is gone when you stop taking the medication, obviously. It is effective at decreasing reoccurrence, but it does have potential increase in adverse effects, right? Because the patient is using an antibiotic on a regular basis, and there is increased antibiotic associated resistance with it. So it is a very viable option in specific cases as it relates to the patients that you're seeing. From a pharmacological perspective, we see 70 to 90% risk reduction with recurrent UTIs when we're using continuous antibiotic regimens. These are some of the examples that we see for a daily dosing prophylactic regimen. And then for postcoital, this would be either right before intercourse or within 2 hours of intercourse, and these are generally 3 antibiotics that we see. So once again, although we can't prescribe this, it's really important that we know what the data is around it. So we have that option to provide counseling and recommendations for patients when necessary. So let's go with our second poll question. Okay, it should be launched. So what is the minimum dose of soluble proanthocyanidins, PACs, and please don't make me say that again, so PACs, required to significantly reduce UTI risk according to a 2024 meta-analysis. So we have 12 milligrams, 18 milligrams, 36 milligrams, 72 milligrams. If you're like, PACs, what is that? Good. I'm glad if you don't know what it is, because hopefully by the end of the talk, we can help you out with that. So we have about 30% participation. Let's get that up at least to 50%, and then we can see how you guys did. Proanthocyanidins. It's a tongue twister. Okay, so we're at 50%. Okay, good. So we have, let me see if I can show the results. So 47% of people say it's C, 36 milligrams. Coming in a close second, 18 milligrams, 33%, and then 72 milligrams and 12 milligrams round out third and fourth. So that's where we're at. The right answer is 36 milligrams. So the mechanism is anti-adhesion, and cranberry products that are standardized to an adequate pack count or content of 36 milligrams taken for 3 to 6 months have the most consistent non-antibiotic evidence for reducing recurrent UTI risk. This was from a large meta-analysis involving almost 9,000 patients, and that confirmed that cranberry products can reduce the risk of symptomatic culture-verified UTIs in women with recurrent urinary tract infection. So what is the mechanism? I always love to understand mechanisms because I will forget the fact, but if you give me a picture, I will remember this. So you have this bacteria, in the bladder, in the ureter, and it will bind to the wall of the urinary tract. And when it binds, that's, then they are able to propagate and lead to infections. What PACs do is they take up these binding sites, and what ends up happening is the bacteria is able to be excreted through the urine and eliminated out of the bladder. And these PACs are effective for all of the major types of bacteria that we see causing uncomplicated urinary tract infections. So the E. coli, the Klebsiella, and Enterococcus. So when we look at non-pharmacological treatment options, we see that they're found in varying concentrations depending on the formulation used. That's important. We're going to get back to that. They decrease the risk of experiencing at least one UTI for patients that are experiencing uncomplicated reoccurring urinary tract infections. And there's really no significant difference between daily cranberry as long as we're using that 36 pack content and a daily prophylactic use of trimethoprim, which was done in a specific study. They have less side effects because we're not taking antibiotics, and also they do not contribute to antibiotic resistance. So those are some of the pluses for using these types of agents as well. And sugar in the juice can also be an issue, especially if they're diabetics. Now, it's important to understand that the evidence currently does not support the use in elderly patients with bladder emptying problems or pregnant women. Data in these groups is still limited to very small studies. So the fact that they're better tolerated than antibiotics and don't have resistance are two very big pluses. From a safety perspective, some cranberry products, and I'm speaking generally here, have been shown to have contents of oxalate, which if you have a patient that has a history of kidney stones, could be potentially problematic. And in vitro, there was an interaction with warfarin. Now, what I will say about CO Plus's agent Utiva is that it is third-party tested. So every container that a patient gets is going to contain that 36 milligrams of PAX, which is very important. And the third-party testing that has occurred also shows that there is no vitamin K and there's just trace amounts of oxalates. So that's reassuring to patients. And the study that looked at the oxalate levels was a study that was done almost 20 years ago, and it just had an N of 11 patients. So even that, obviously we want to be on the cautious end of things. We want to provide that information to patients, but clinically, it's really not something that I've seen in practice. It's also important to understand that not all cranberry supplements are the same, right? Standard cranberry products will contain an insufficient amount of PAX, usually 0.5 to 1%. Utiva has a 15% concentration. So when you're getting a 240 milligram cranberry fruit extract, you're actually getting the 36 milligrams of PAC, and that's 9 times more. So when you look at comparing concentrated juice powder or whole fruit powder, we see much lower levels of sugar and also much higher concentration of the active ingredient, which is effective. It's also a better way to treat and prevent UTI. So here we see these are products that contained 36 milligrams of PAC. These were maybe private label cranberry products. So you can see that this was an in vitro study looking at adhesion to the bacteria. So you see the private label products didn't have any adhesion properties. The ones with 36 milligrams of PAX did. Utiva still had the most adhesion out of the 3 that were studied. When you're looking at pricing and you're looking once again at the activity, the adhesion strength, you also see some of these differences compared to other products. And another study was looking at patients that had less than 5 recurrent UTIs over a 12-month span. And the data showed that there was a 46% reduction in recurrent UTIs for patients that used the 36 milligram PAC dosing. And this study specifically looked at the 36 milligram dose compared to the 2 milligram dose to see what would be the most effective dose for patients. And this was used over a period of 12 to 24 weeks. So Utiva dosing is very simple. It's 1 capsule. It is important for it to be used at the same time because the efficacy will wane beyond 24 hours. So it's important for patients to be compliant with this. And like I said, from a third-party testing perspective, no vitamin K and just trace amounts of oxalates. So let's look at some other non-pharmacological agents that can be used. So one very common one is D-mannose. There is conflicting data on this. There were some earlier smaller trials that suggested that D-mannose might be beneficial, but in 2025, they did a systemic review of 4 RCTs with about 900 patients, and it showed no statistically significant reduction in recurrent UTIs. And there was another study that looked at about 600 women with recurrent UTIs using D-mannose for 6 months, which also did not show any decrease in future infections. The other agent that we sometimes see is lactobacillus probiotics. Orally, they have also not shown. I mean, in Canada, there is just the oral probiotic lactobacillus capsule that you can use. It has not been shown to have any significant decrease in recurrent UTIs. There is a vaginal one, but it's not available in Canada. I think it's going through phase 2 trials right now. So right now, the 36 milligram pack containing options would be the most effective. And also, just briefly talking about from a hormonal perspective, hormones like estrogen, local estrogen, low systemic absorption, systemic risks are very low, and they help to restore local lactobacillus and pH. And multiple studies have shown this. So, from a recommendation perspective, it's also recommended that if you have a perimenopausal or a postmenopausal woman, that this is looked at. And obviously, we can't prescribe this, but we can still make the recommendation to a physician to have this taken care of and looked at. For symptom support, we have sodium citrate, which many of you know and use and recommend. The key thing here is to, if it's an uncomplicated case, to do the minor ailment, prescribe the antibiotic, and then provide this for symptom control. Because what we don't want is a patient leaving with just the sodium citrate, the burning goes away for the short period of time that they needed it for, but in the background, the bacteria continues to multiply. And now that uncomplicated case turns into a complicated case. So it's useful by changing and alkalinizing the urine, but it's really important that we prescribe that antibiotic to get to the root upstream cause of what's actually happening. So poll question number 3, let me see how I'm doing on time. I think we should be good. So let's go ahead with this question as well. So I gotta get faster on my clicker. Okay, so when should a pharmacy assistant or pharmacist ideally follow up with a patient who is prescribed antibiotics for a UTI? So within 24 hours, at about the 3-day mark, only if a patient calls back with a complaint, or 14 days after, 7 days after the course is finished. I think I was like 14 days is like too obvious of a wrong answer, so I think I changed it to 7. So yeah, we're well on our way, 50% at 3 days, 90%, sorry, 50% of respondents, but 90% of you are saying at 3 days. And that is the correct answer. So thank you. So follow up. Recommended at 3 days. And let's utilize our whole team here. Let's get the pharmacy assistant, let's get the tech involved to have that follow-up call 3 days after you've done the assessment. And only if there's some changes to the patient's symptoms, maybe they have flank pain, maybe they have a fever, then have them be referred over to you as the pharmacist, where you can make the judgment call if you want to refer or if you want to provide any supportive care. So that's that with the follow-up. So now let's revisit Janine and see what's going on with her. So we briefly brought this case up. 32-year-old marketing manager comes to you on a Friday afternoon with recurrent UTIs. This is what's going to be her third in the past 11 months. She's looking for immediate relief, and she's really frustrated with these reoccurring episodes. So let's use the Scholar-Hams framework here. And as we go through it, we see that she's presenting with the majority of those primary symptoms. She has 3 previous culture-confirmed UTIs. She was using macrobid for each of those. The onset was about 36 hours ago. It's localized suprapubic pain. It gets aggravated after intercourse, or it comes up after intercourse. And she is currently using spermicides with her partner. She's drinking water as much as she can, but she does have regular meetings, and she's ending up holding her pee, and she's having a challenge with a couple of those types of non-farms. She's sexually active with one partner, and episodes, she has been linking the episodes to having them after intercourse. So what can we do with her? So what does the medicine 2.0 approach look like? What usually happens? And by usually, I'm saying my own experience in terms of what happens with colleagues that I'm working with. So you assess Janine, you confirm uncomplicated cystitis, and then you go ahead and you prescribe nitrofurantoin, BID 5 days, macrobid. You recommend the sodium citrate because she is in need of something more immediate for her symptoms. And you tell her call in 2 or 3 days if symptoms don't get better, or you tell her you'll call in 2 or 3 days. And that's usually the end of the consult. What ends up happening, we have 90% efficacy rates with macrobid. So she feels better in 3 days, she finishes the antibiotics and returns to normal life. But what happens later on, right? 3 months later, guess what? Janine's back with another UTI. So now let's look at the medicine 3.0 approach. And what does that look like? So firstly, we're doing the same thing. We're starting with medicine 2.0. We're prescribing the antibiotic, providing the symptom control and help. But then step two is looking at some prevention counseling, right? Where you say, listen, Janine, you've had 3 UTIs in 11 months. You fall within the category of having recurrent infections, right? More than 2 in the last 6 months or 3 in the last 12 months. Let's talk about how we can stop this cycle to help you from keep coming back. Like, how does that sound? And just getting that confirmation from the patient that that's something that they're interested in. And then we're going to start with behavioral modifications, right? Discussing that fluid intake, talking about the importance of peeing after having intercourse, looking at maybe some alternative methods of contraception and potentially having a conversation, discontinue the spermicides and linking the spermicide use with these recurrent infections that she's having, and re-educating her on the importance of not delaying the voiding. So every time you're going in for a meeting, anytime you're going to be in the car for more than half an hour, just pop into the washroom and make sure you're fully voiding. Continuing on with that medicine 3.0 approach is having discussion about non-antibiotic prevention. So, there are evidence-based non-antibiotic options that can help you reduce your risk of having these recurrent urinary tract infections. So once again, asking for permission to have that discussion. Are you open to learning more? And then we can recommend a product that contains 36 milligrams of PAC. And this is based on trials in women very similar to you that have had more than 2 UTIs in the past 6 months. And the overall benefits of this is it can help to prevent future episodes for you. And then, we can recommend that PAC content, and she's going to be seeing you because you've provided this extra education. And if you find that behavioral changes and the non-RX of using the 36 milligram PAC fails, then we can get into a discussion of putting her on a daily antibiotic, or perhaps in her case, maybe an antibiotic that she uses post-coitally. So, let's try these behavioral changes first and cranberry. And, if you're still getting UTIs in 3 to 4 months, then why don't we revisit this option? So what is the pharmacist's role, right? We want to assess, we want to prescribe, and treat uncomplicated cases within our scope, and be very aware of this pressure that we still might have to prescribe an antibiotic. We are gatekeepers of these antibiotics, and we really do have an important role to play in terms of mitigating and preventing antibiotic resistance in our communities. Secondly, we want to prevent reoccurrence. So counseling on evidence-based options that are potentially non-antibiotic in nature. And hopefully today we provided you with some information on 36 milligram PAC available products that are available in your stores and in your pharmacy. So we have a tool that has evidence behind it to provide patients with added level of care. And then just, thinking back to this medicine 3.0, every time you're counseling a patient, do you have this ability to initiate a conversation on what we can do to prevent a situation from happening in the future? It's great to always put out the fire, and firefighters are very good at this. And I think as pharmacists, we're pretty much firefighters in a past life. We're very good at putting out fires, but are we having conversations about this medicine 3.0 approach? Are we having conversation to say, okay, I've put out the fire now. Now let's look and take a view of what's actually happening to see what things are happening in this case that are making that fire continually coming back, right? We have to be preventative in nature to prevent this from happening. Putting out the fire, but then also looking upstream. It's like an example I give. If someone falls into the river, the first thing that we do is we help rescue that person and we get them back on shore. And then the next thing that we should be doing is asking ourselves, okay, why did they fall into the river? Was it the fact that there wasn't any fencing up? Do we have to put more signage up? What is the reason that this happened? And it's really important that we start asking ourselves these questions to, help our communities live better and also increase the loyalty. Because when you have a patient that you've helped by giving them added information that they never came in contact with, they're going to be your specific pharmacist. And I know many of you have been doing this for a number of years, and you can probably speak to that better than even I can. Start, stop, continue. So, from attending this webinar, this is something as a pharmacy owner, we use this a lot during our quarterly reviews and meetings. Anytime there was a presentation or we were learning new information, I always wanted to challenge my staff to ask them, what do you want to start doing from this knowledge? What do you want to stop doing? And what do you want to continue doing? So I just wanted to take a few minutes here and ask you these questions. And I'd love for you to put this into the chat. As a result of this information and this discussion that we've had here tonight, what is one thing that you will start doing in your practice? And what is one thing that you'll stop doing in your practice? I think the list of what you're going to continue to do, I'm pretty sure that's going to be a very long list, so we'll leave that. But I would love to hear for you to add in stuff into the chat about what you would start doing and what you might stop doing as a result of learning this information. And with that, happy to take some questions.
All right. Thanks, Manjit. That was a great presentation.
So
Very, very.
I spoke very fast, but I wanted to get through the stuff, so I hope people could follow along okay.
No, absolutely. I think your pacing was great. Okay, we have some questions. I'm thinking perhaps maybe we can look at what people are putting into the chat right now based on your most recent prompt. So more prevention, giving pamphlet on UTI prevention, starting to offer packs, very well spoken. Okay. Okay, let's move into some of the questions then. So a question that came up earlier on in the presentation when you were talking about some red flags was you mentioned long-term care, and someone asked why would long-term care be a red flag?
So I think long-term care is a red flag just because there might be a considerable number of other chronic diseases that are actually happening. So it's unlikely that it's going to be an uncomplicated situation. They also could have an indwelling catheter. There could be a lot of other complex cases there. So in that case, it's better to refer because we don't want to prescribe and overarch what is in our scope, which is predominantly uncomplicated cystitis and bladder infections.
Okay. So you mentioned Cysto Plus, but what do you think about using Pyridium?
So Peridium used to be used in Ontario. It's been off the market for a while now, and I think it used to be something that we used to use because it was prescription. I actually don't know the reason why it was taken off, but it's not available in Ontario anymore. It could be a supply issue or a coverage issue. I'm not sure. Peridium used to be used. I mean, in this case, I think Cystoplus is very effective. It's over the counter. If they have a drug plan, I think it's a viable option. If that price is an issue, then we can put it on or ask for a prescription and get the Peridium on prescription. But otherwise, I would just go with the Cystoplus. It seems to be very effective. It alkalinizes the urine and takes away some of that sting. And the key thing is, once again, as I mentioned, just to make sure that we're prescribing something that's going to take away or help to take away the cause of the infection, which is killing the bacteria.
Okay, great. And yeah, Pyridium is back on the market. I was at a conference
It
late
is.
last year, and it was a supply issue. Yeah, it's back.
It's a long supply issue. Yeah, that kind of. So as a pharmacy owner, so I stopped practicing on like a full-time basis. It's been a little bit over a year, so it must have made its comeback within that time.
Yeah.
Thank you. Always love learning things.
Yeah, let's see here if there's anything related to that. Yes, it's back on the market again. And somebody did make a comment. Sodium citrate is OTC, Pyridium is RX, and likely benefit, as you said, if they have insurance. So, okay, good to know. Somebody has asked, how does Cysto Plus work? I think you kind of mentioned that
Yeah, just
during.
it all so it's 3 sachets used over 2 days, so 6 sachets in total, and it alkalizes the urine. So it just basically increases the pH of the urine and takes away some of the burn. It's a very symptomatic. It's not helping to treat or treat the active infection or doing anything from a prevention perspective. It's basically like someone has burning sensation and they need help immediately, and that's why it's recommended with an antibiotic because, as you know, antibiotics can take at least a day before their patient is going to notice any benefits, whereas Cysto Plus can work much faster to help relieve some of those symptoms of dysuria.
Okay. So when would you prescribe fosfomycin instead of macrobid?
Yeah, so fossil is interesting. Its resistance rates are very low, so it's pretty susceptible across a lot of different jurisdictions. The resistance rates are very low. I my personal thing is when I have prescribed it or seen it being prescribed, I quite often see patients come back. There's a couple of reasons for that. One of which its absorption into the tissues is a lot less than what you would see with macrobid. It doesn't concentrate as strongly as it does. So the other thing is it's quite a bit more expensive. So for those reasons, it's usually used as like a third line agent. If you have susceptibility to Septra in your area, so in ICAS in Oakville, for instance, I think the susceptibility on that antibiogram was about 77%. So if I'm doing consults, I'm recommending macrobid, and then I'll forego Septra because of the high rates of resistance to E. coli specifically, and then I'll go with fosfomycin as a second agent if there's a drug planned.
Okay. So, okay, some questions here on PACS. The client needs to take PACS for minimum 3 months to work, question mark. Should we suggest an analysis?
So from what I know, the studies were 12 to 24 weeks. So yeah, you're looking at about 3 months to prevent one recurrent urinary tract infection. Could you go for analysis? So with the analysis thing, based on the guidelines, even if they have if they have bacteria in their urine but they're asymptomatic, we don't prescribe antibiotics. So if they're asymptomatic, then that's fine. That could be an option. But regularly right now, they would have to continue it for at least 12, anywhere from 12 to 24 weeks based on the studies.
Yeah. And I would just add to that, when it comes to the PACS and like that time frame, um, what we've learned is that if the true cause of the UTIs is not being addressed, the PACs are really just there to help prevent the bacteria from sticking, right? So it's a lot of patients decide to just take it
Mhm.
for as long as they need.
Yes.
Okay, next question. Covered that. Any information on using prophylactic antibiotics for longer than 12 months?
There could be, but I would switch the antibiotic then, just because the chances of resistance significantly go up if you're using an antibiotic for that length of time. I mean, generally speaking, the resistance rates with the antibiotics that we see are generally better than some of the other antibiotics that we see being prescribed for other conditions. But still, if you're using the same antibiotic for 12 months, then it might make sense to switch over and use a different antibiotic at that time. So it's mainly basically based on resistance.
Okay. So this is just a confirmation. Hypertension is contraindicated with Cysto Plus because of the high sodium, right?
I believe so, yes.
Okay. Okay, great. Um, Another on prophylactic antibiotics. How effective are they for preventing recurrent infections?
70 to 90%. So using a daily antibiotic is about 70 to 90%, decreasing the relative nature of recurrent types of infection. So it is very effective. Once again, it comes at a higher cost. It comes at the expense of potentially more side effects and also resistance. So it's definitely like a risk benefit analysis that you need to have a conversation with the patient. Some patients want to avoid using long-term antibiotics for those reasons, and other patients are okay with it. So either are viable options. I think that's a case by case basis that you would have to have with the patient, understanding, what their needs and what their desire is.
Okay, great. Another question here. What about probiotics usage for UTI prevention?
So in Canada, there's an oral probiotic that is specifically used for this purpose, but in the studies are conflicting. They do not show any significant benefit. I briefly mentioned there is a vaginal probiotic that is in, I think, phase 2 trials, which has shown it's a lactobacillus. It's a funny second name. It has shown promising benefits, but it's not yet available in Canada. So if you're using an oral probiotic, it doesn't have enough information, and that information does not compare to using a product like a 36 milligram pack for preventing urinary tract infections.
Okay. There's another question, more information on packs regarding availability. If we can talk about that after, like if anybody wants to hang on in the product presentation, we'll be happy to talk to you guys about where you can access it. Another question here, can fosfomycin be used for both male and female patients for UTI?
Yes.
Okay. Okay. Are there any other reasons that prescribing for postmenopausal women may be a problem other than the role of estrogen? Is the bacterial etiology complicated?
No, bacterial etiology would be the same. It's mainly for the hormonal purposes because chances are, if they're on a hormonal agent, that's going to take away a lot of the recurrent nature of the infection. So it's really making sure that the patient isn't continually coming back for more consults and getting more antibiotics when using a low systemically absorbed estrogen product would, remove a lot of the potential challenges around that. That's really the reason behind it.
Okay. I think we can do about two more questions.
Sure.
So the next one here is, with the elderly, are the prophylactic antibiotics used? Sorry, I'm just trying to clarify this. Okay, I think what they're asking is, within the elderly population, what are the prophylactic antibiotics used and what is the efficacy?
I don't know if they've done any specific studies in the elderly. I would assume that it would be same antibiotics as per the guidelines from the AUA and the CUA, Canadian Virological Association. Yeah, I wouldn't be able to speak to if there's any specific studies looking at that population, if the etiology would be a little bit different. I know in institutional settings, like I mentioned, there is E. coli makes up less percentage of those, about half of those infections, and then you have other gram-negative bacteria making up the rest of it.
Okay. Okay, so that's about it for our time, and we've covered most of the questions. There are a couple questions on the products, and we'll cover that after the presentation if you guys want to hang on. So yeah, with that, I wanted to thank you so much, Manjit, for sharing your expertise and your knowledge and your time. It's been great.
Great, thanks for having me, and I wish everyone a great evening. And remember, the start stop. Great to take this information and use it in your practice. So thanks again, and everyone have a good night.